So I think people have arrived in. Okay. So good morning, everybody. Welcome to a rather nice Monday morning after a beautiful weekend. Hope you all had a good weekend. Welcome to this session. This is about embedding the patient voice in the centre of a national quality improvement programme. I'm really interested today to hear from everything that the National Cancer Audit Collaborative Centre have been doing, and you're going to hear the same thing. You'll have a chance to ask some questions towards the end as well. But this is really about sharing what's been done in this space. My name is, if you flick the next slide, please. So I'm Chris Carrigan. I'll just wait for the slide to go. Oh, first of all, yes, housekeeping. Just to say, you will have probably noticed when you logged in that the webinar says it's been recorded, and that's going to be available on the website shortly afterwards. Because the mood we're running in, your microphones are automatically switched off, but we'll do some questions at the end of the session, just to keep our time in control, rather than doing them after individual presentations. If you've got questions, you can post them at any time. If you try and use the Q&A box rather than the chat function if possible, so whenever you get a question coming in, just feel free to post it. It's there when we get to the end, and we can pick up the most popular questions and pick those up when we do the Q&A towards the end of the webinar. Okay, thank you. So briefly, as I said, my name is Chris Carrigan. I'm the data advisor for Use My Data. Use My Data is a movement of patients, relatives and carers who want data to be used for patient benefits, to drive research, to improve care, to audit clinical activity. Exactly what NATCAN do for their day jobs. My job within Use My Data is to act as their data advisor. So my background is heavily in health data, lots of it in and around the audits as well, in different guises. And all I really wanted to do today is to introduce the sessions, make sure we get to time and give you enough time to get to questions at the end. I think when I was reflecting on this to start with, I thought, well, lots of people on this call, obviously, we work in this space of patient involvement, patient data, and sometimes it can feel quite isolated. So it's really good that the NATCAN team have put this session on as part of our National Patient Data Day, Data Month sessions, umbrella sessions, to explain how they operate with patients and data, how they involve patients in the data work, the data decisions, the data outcomes in what they do. And indeed, you'll hear at the end how those different audits now begin to bring their patients together, because it can feel quite isolating. As part of this work, as I said, I may already mention the National Patient Data Day, which is in this week on Wednesday, and this is an umbrella session and a part of that. And the whole concept of National Patient Data Day was to bring organisations like NATCAN, Use My Data, and many others under that umbrella, so we can begin to share all our experiences working as patients with patient data. So really pleased to be given the opportunity to chair this session today. You'll see from the agenda we've got Julie will start the session talking about NATCAN themselves, and then we're going to go through various aspects of how patient involvement works across NATCAN and look at some specific audits. It'll be pancreatic cancer with a video from Christine. If you just switch to the next slide, and then moving on to lung cancer audit and the NHL audit, and then talking about a wider perspective of a network of patients, which is very much where my heart is as well, leaving some time, as much as we can time, for Q&A at the end. I hope that sounds all right to people. In which case, I think we better get cracking, as we've shortened time already. And I'll ask Julie if she could introduce herself and take us through the first session talking about NATCAN and introduction to NATCAN. Julie.
Thank you very much, Chris, and thank you, Use My Data, for giving us this opportunity to talk about NATCAN and the work that we do, where people with lived experience are very much at the heart and the centre of all of our work. I'm Julie Nossiter. I'm the Director of Operations for the National Cancer Audit Collaborating Centre. Okay, so I thought I'd start with what's national clinical audit. So national clinical audits use data to check care against agreed standards. So this might be guidance from NICE, for example, the National Institute of Clinical Excellence, and to compare performance across hospitals and to share learning to improve the safety, quality and outcomes for patients. Next slide, please. So NATCAN was established in October 2022. So it's a new national centre of excellence. It aims to provide regular and timely evidence to NHS services about where and why patterns of cancer care vary, and to support local quality improvement. We're commissioned by the Healthcare Quality Improvement Partnership, and funded by NHS England and the Welsh Government. And we currently have funding in place until September 2027. Next slide, please. So NATCAN, we like to describe ourselves as the home of all 10 national cancer audits in England and Wales. So when we first were lucky enough to be awarded the contract for NATCAN, it included 6 new audits. So these are new audits in breast, primary and metastatic. So they're 2 separate audits: ovarian, pancreatic, kidney cancer and non-Hodgkin lymphoma. So these have been set up for the first time by NATCAN. NATCAN's based in the Clinical Effectiveness Unit at the Royal College of Surgeons, and this is a long-standing partnership since 1998 with the London School of Hygiene and Tropical Medicine. So the Clinical Effectiveness Unit's been successfully delivering audits for a number of years. So this included 4 pre-existing or established audits in lung, esophageal, gastric, bowel and prostate cancer. And each of these 4 long-standing audits moved into NATCAN in 2023. Next slide, please. So this slide summarises the key features of NATCAN. So we have multidisciplinary audit teams, which are based on a close partnership between clinical leads. So by clinical leads, we mean NHS consultant surgeons, oncologists or medical oncologists, and methodological leads. So these are our academics from LSHTM. And together we have a broad range of expertise in cancer care, data science, statistics, clinical epidemiology, performance assessment, organisation and logistics. We've formed close links with a broad range of stakeholder groups. So this includes clinical professional bodies, as well as people with lived experience and patient charities. We don't collect data, we use data that's already available within the NHS. Also, one of our key features is that the work that we do is informed by research and development. This makes sure that we carry out fair comparisons between hospitals and look to see where there's variation and why there's variation. Next slide, please. So this slide, don't worry, I won't go through this in detail. This is our organogram. So this illustrates the structure of NATCAN. So this includes members of our 10 audit teams. There's about 65 of us in total. Each audit has a clinical or advisory stakeholder group. We have a board and an executive team who are accountable to the board for the delivery of NATCAN. We recently welcomed our new clinical director, Dr. Tom Rokes, who's a clinical oncologist and was previously vice president for clinical oncology at the Royal College of Radiology. Next slide, please. So we're very fortunate to work closely and be supported by a broad range of patient charities. Next slide, please. So we also work with people with lived experience who are at the heart of everything we do. So we worked with our close patient charity partners to recruit for a patient and public involvement forum for each of the audits. So my colleagues in NATCAN will dig into this in a bit more detail shortly, providing an illustration of how we work together and some examples of the work we've delivered together. Next slide, please. So since we were awarded the contract for NATCAN in 2022, we've been incredibly busy building our team, setting up the audits. Each of the audits is now established and are regularly reporting results and driving quality improvement. Next slide, please. So going back to the beginning of NATCAN, we carried out a scoping exercise to define the scope and the parts of the patient pathway that the audits would focus on. And we built 5 quality improvement goals targeting those priorities. Throughout the following year, we continued to work closely with our stakeholders, including people with lived experience, and we developed what are called performance indicators. So these are metrics which we publish using our routine data. So these are used by the audits to monitor progress towards the quality improvement goals and to provide a better understanding of the reason why there's variation in the treatment of people with cancer and the outcomes they experience. Next slide, please. As I mentioned, data is not collected for NATCAN. Instead, we use routine existing NHS datasets, which are submitted routinely by hospital trusts in England to the National Disease Registration Service and health boards in Wales to the Welsh Cancer Network in NHS Wales. So this provides information on the diagnosis, management and treatment of all patients newly diagnosed. So this is information about the stage at diagnosis, the mode of admission, was it an emergency admission, for example, pre-existing conditions, surgical procedure, radiotherapy and chemotherapy details, and outcomes following treatment. So this might be readmissions, complications, and survival. So it's important to note that all identifiable information is removed before data are provided to us in NATCAN. Next slide, please. So this slide just illustrates really the depth and breadth of the data sets provided to NATCAN. In England, there's a lag of around 2 years before we receive what's described as gold standard cancer registry data. However, an innovation during the COVID pandemic was the creation of more rapid cancer registry data. So this is more limited in scope, but by linking with other data sets, we link to information about patients' treatment and care. The benefit of this data is that it's available 4 to 6 months after diagnosis. Next slide, please. What's missing from the data sets is patient-reported outcome measures. So these provide important information on patients' views on their functioning and quality of life after treatment. So the prostate cancer audit was unique within the cancer audits that it received additional funding prior to joining NATCAN to carry out a patient survey, and men were asked about their views on their outcomes. So this for following radical treatment for prostate cancer. So this is the impact of radical treatment on patients' sexual, bowel, urinary function. There is a National Cancer Quality of Life Survey, and this was carried out by the National Disease Registration Service. So we're hopeful that this data set will be available to us in NATCAN in due course. Next slide, please. We do receive information from the National Cancer Patient Experience Survey, and in the prostate cancer audit, we worked with members of our PPI forum who were co-authors, and we explored variation in how care was experienced by different patient groups. Next slide, please. So using the availability of rapid data and using this data enables us to report in England currently on a regular quarterly basis to drive local quality improvement. So a key innovation are our data dashboards, which we add features to each quarter. We consult with people with lived experience, we consult with clinicians. So we add additional features, different additional reporting functionality every quarter. Next slide, please. Each audit also publishes an annual State of the Nation report. So this describes a national patterns of care against measurable standards and includes 5 key recommendations for action. A patient summary is also developed working in collaboration with members of each audit's PPI forum. Next slide, please. So this slide just summarises the months when the reports are published, both in 2026 and in 2027. Next slide, please. The use of the quarterly data dashboards has enabled the audits, and this more rapid sort of audit and feedback has enabled each of the audits to select a particular area of care where improvements are needed, and they've designed what's called a quality improvement intervention. So more information about that's available on our website, and people with lived experience have been supporting the audits in the development of these. Next slide, please. So the audit teams were very engaged with the clinical community, both at a centre level. Next slide, please. And the individual audit teams out there at conferences, holding webinars, getting the results out there in the clinical community. Next slide, please. We were also delighted last year to participate in the first ever National Patient Data Awareness Day. Some members of the team, Vicky and Olivia, attended on behalf of NATCAN and entered in what was called the Data Soapbox Challenge. And I love this quote from Olivia, our clinical fellow from the OG audit. We don't use names or NHS numbers, but every number in our data represents a person, a life, a family, a story. And we have a responsibility to use that information with purpose to make care better, fairer and faster for everyone. Next slide, please. And this is just our final slide, just the next steps for NATCAN. We want to strengthen our engagement, both with clinical communities and people with lived experience. We're going to develop further innovations in reporting and feedback. Obviously, key centre to the work that we do is to stimulate improvements in cancer care, and we're looking beyond October 2027, where actually the retender for NATCAN is in progress at the moment. So we're hopeful that we will secure additional funding beyond October 2027. Thank you very much for listening. So I'll
Julie,
hand
thank
over.
you.
Sorry, Chris. Over to you.
I was jumping into your hand over there. I was just say thank you. That's a really useful introduction to what NATCAN have done. I think it's a remarkable organisation that's risen from several different ashes over organisational change. So really good. Just a reminder to people, if you've got questions at any time, put them in the Q&A. So we've got a list of things when we need them. Thank you, Julie. We're going to move on to Verity now about establishing the PPI, Patient Public Involvement Network forums across NATCAN. So Verity, we're all yours.
Thank you, Chris. Yes, so nice to have everyone on the meeting today. My name is Verity Walker. I'm the Centre Project Manager, working really closely with Julie and across the different audits as well. So I'm just going to talk a bit more about NATCAN PPI forums and about how we've sort of set them up and a few examples of what they do. So firstly, just a quick summary, really, a quick snapshot of what the PPIs are. So PPI, as most of you know, stands for Patient and Public Involvement, and we have a group per audit. So that's a group, they're consultative groups representing the patient's view, potentially also carers as well on those groups, and charities. And they support, for example, support the process of selecting and reviewing performance indicators, and just act as a consultative group on a number of different outputs. So some of those outputs include patient and public information materials, summaries of the annual State of the Nation reports, audit infographics to aid dissemination of key information, and also co-development of scientific papers as well. The other thing that PPIs are involved in is being a key part in developing the audit web pages. So an example of that is very recently, September last year, we released our new website. So the patient and public involvement forums were involved in a key consultant in developing those. And then, just in general, they're also involved in the quality improvement goals, the different activities related to that, and many different outputs, which I'll go through in a second. So firstly, how did we go about recruiting the members of our PPI forum? So we have 10 audits, so 10 different PPI forums. So how do we go about doing that? So we worked really closely with the patient charities. We created really close working relationships with representatives from each of the patient charities and took a really collaborative approach. So that involved, for example, the charities tapping into their existing networks, which were really, really useful to sort of get expressions of interest for people to join our group. So some charities also use their social media to promote it, also pop-up adverts on their websites to reach that wider audience. And we also put together lots of different resources to support that recruitment. So in terms of reference, adverts, expressions of interest forms, and in some cases, patient booklets as well. And then what were the first steps? Once we had a group, what were our first steps to set up the PPI forum? So we underwent recruitment with the patient charities, as I mentioned, and produced documentation as well. Key step was to have that first meeting. So we did that. It all happened virtually over Teams. And a key part was to ensure diverse representation, of course, across all different groups. So I'll go into that in a bit more detail in a second. And then we also confirmed a PPI chair for each of those groups. Okay, so this is just some activity and involvement examples of what the patient forums are involved in. So this is just a really small snapshot, but just a quick overview. So one example is they're involved in the development of the patient summaries of the annual State of the Nation reports. So you can see on the left there the example from the latest report, which the ovarian cancer audit has published. Also website content, so development of the new website, but also different forms of content, for example, blogs, newsletters. And you can see there the red box is actually a quote taken from the short blog prepared by the non-Hodgkin lymphoma PPI chair, Frank, and he is actually on the call and he's going to present shortly. So that's really exciting, and we're really appreciative for all of the work Frank does. And patient information and resources. There's loads that goes on. This is just a screenshot here at the bottom right. This is a from consultation with the breast cancer audit PPI group. This is an output that came out of that. So it's just a summary of the steps for a typical breast cancer pathway from diagnosis to treatment. I've got some more examples here on the next slide as well. So the audits have been really busy with their quality improvement interventions. So that's another thing that we've been busy with, and the PPI members have been really proactively supporting those. So shaping QI priorities, the activities and events as well. So you can see here the bottom two pictures. We have Frank, again, he presented at our quality improvement event in 2024. And then in the middle there, I've got Sabah, who presented at the 2025 event. So yeah, it was great to have them sort of be a real part of the day. And yeah, just further website and data dashboard development as well. We're receiving support and advice on those from the PPI members too. Okay, yeah, so just to talk a bit more about the representation overview in the groups themselves. So a key part, as I said, is to make sure we have diverse representation in each of the groups. So yeah, as a snapshot, that covers all of these different aspects here. So geographical location, stage, gender, age, ethnicity, and treatment. And we're keeping membership at all times under review. And if there are any gaps, we will actively work to address those and take on further recruitment, again, with support from our charities. Just some next steps. We're reviewing representation and recruitment, as I said. Working with PPI reps during the re-tender for NATCAN is a current activity, which Julie spoke about in her presentation. Working with our centre level PPI group, or PIN, which Vicky is going to talk a bit about later on. And yeah, continuing to work closely with our patient charity stakeholders. Okay, so I'm going to pass it over now to Christine. So I've got this video from her. I'm going to play it in a second. But yeah, just to express gratitude for Christine, who put this video together. She's from the pancreatic PPI group, and she's speaking about living with and beyond with pancreatic cancer and her experience with the pancreatic cancer audit. And this film was produced as part of their quality improvement work. So I'm going to play this now.
In 2021, I was diagnosed with pancreatic cancer. I'd felt reasonably well, albeit with some weight loss and atypical GI symptoms, and I'd been back and forth to the GP for about 7 months. After the 5th unfruitful visit and a suggestion of more meds, I declined those and asked for a referral letter which I could take to a private specialist. What followed was a consultation and a diagnostics which unearthed my pancreatic tumour, after which referral to an HPB specialist was promptly made. Meeting the surgeon and being presented with the full picture and potential treatment options, heavily caveated with the dire prognosis stats, was hard to hear. On reflection though, I know I was fortunate to have been treated in a major HPB centre at the Manchester Royal Infirmary, and my care there by the whole team, but led by the superb surgeon and his wonderful CNS, was excellent. From the get-go, the surgeon talked with me about staying as well as possible before and during all the treatment, eating well, staying hydrated, gentle exercise, sleep. It really seemed strange advice at the time when my world had just fallen apart and I really thought I was going to die. But I now know it was trying to make sure I got the best outcomes from all my treatments. It was also important because it gave me back some control. They were things that I could do to help myself. Following an uneventful post-op recovery, I was referred for adjuvant chemotherapy to the Christie Hospital in Manchester, another centre of excellence. How fortunate was I? Months of chemo followed, gruelling, but achieved, and I remain well now. Once I was in the system, I had few problems accessing treatment. I researched all the options before they were told to me, and so I knew that the surgery and the chemo I was being offered were gold standard. I'm a tenacious person, and I had enough physical and mental strength to advocate for myself. My time now is spent in supporting others who've had a pancreatic cancer diagnosis. My advice to them is to try to educate and advocate for yourself if you feel well enough to do so, or to ask a loved one to do that on your behalf. It really is important. Reaching out to the treating team, general practice or charitable sector, for example, Pancreatic Cancer UK, which is superb, can be really helpful. The implications of this diagnosis are overwhelming, but I urge people to push for explanations if they don't understand, not to be afraid, and to ask for second opinions, particularly from HPB specialists if they believe that would benefit them. Unfortunately, I know from interactions that I've had with people who've had a pancreatic cancer diagnosis that the treatment package I benefited from isn't universally offered throughout the UK. That there's a huge gap in the narrative around pancreatic cancer and an inherent negativity about the disease. Without doubt, this is an aggressive cancer where the outcomes are frequently poor. In fact, they haven't changed in decades, but it is important to offer treatment to those people who may benefit if we're ever going to shift the dial on this. Data from the National Pancreatic Cancer Audit suggests that across the UK, only just over half of those diagnosed with non-metastatic disease receive any form of disease-targeted treatment. While some people in this group may be too frail to tolerate such treatments, statistics confirm that of those with a good performance status at diagnosis, only 2/3 receive disease-targeted treatments. Worryingly, these are average stats, and there's wide variation in treatment rates across NHS provider trusts. A diagnosis of pancreatic cancer is devastating and shocking. Many people, if offered, will accept treatment if they believe it will save or prolong their lives. Unfortunately, the reality is that the opportunity for a positive outcome is not being realised because treatments are not always being offered to those who may benefit. I appeal to healthcare teams, provider trusts and cancer alliances to work with the National Pancreatic Cancer Audit team to fully understand their own performance data and benchmark position in respect of treatment offers, and to engage with best practice initiatives in order that patients are given the best chance of survival. We all deserve it. In 2020,
Yeah, I'm not sure we need to say anything other than what we've just heard. I think is a remarkable talk by Christine explaining her own personal circumstances, but the real significance of what NATCAN do in terms of using the data to understand variation so we can actually do something about it. That's excellent. Let's move on to the next audit, which Lauren's going to talk about, the National Lung Cancer Audits. Lauren.
Hello, good morning, and thank you everybody for joining. So my name is Lauren and I'm the Clinical Fellow working on the National Lung Cancer Audit. And I'm going to share some slides with you today to talk about the Patient Public Involvement Forum that we work with on the National Lung Cancer Audit. Next slide, please. So we've heard quite a lot about what the different audits do within NATCAN, and just briefly what we do in the lung cancer audit is we look at the patterns of care and outcomes of people who have lung cancer in England and Wales, and we try to support NHS services to make the quality of that care better. And here are some of the team presenting some of our work and the outputs that we share, including our reports and then the fancy graphs that we make as well. Thank you. So going back to 2023, we didn't have a PPI forum. And so the direction of the audit was very much led by the professionals we have working on the team. So we have clinical expertise from surgeons to oncologists and respiratory physicians. We have data experts, statisticians, data scientists, methodologists. We have people who have expertise in policy and guidelines, and we have charity representation. So Roy Castle particularly come to all of our meetings to try and give us some guidance. But what was really missing before 2023 was something in the middle of all that. Next slide, please. So what we wanted to do was try and bring the patient voice into the middle of all of that and really set the direction of the audit from there. And the best way we thought we could do that was by building our own PPI forum. So how did we go about it? Well, 2023 is when we started that journey. So we partnered up with our trusted charities of Roy Castle and Ruth Strauss to get some guidance on how this was going to work. We put the advert out, we shared it on social media, on websites, and got in contact with some patient advocates that have worked with the charity before. We invited people to send us applications, more just so we could find out a little bit more about the perspective that they could bring, whether they were a patient themselves or whether they were a family member, friend or relative of somebody who had been through lung cancer care, and which kind of treatments they had had. I've put here careful selection, but what I really mean by that is we just wanted a really wide range of views because we wanted everybody's experience to be heard and valued. And then we set it up and then we got going with our PPI forum. Next slide, please. So we sent out some welcome booklets where we tried to explain what the audit is, what the aims of the audits are, and what we wanted patients to be able to contribute to it. And we sent them out an introductory pack with the booklets, with some of our recent reports and the terms of reference of joining the audit PPI group. Next slide, please, Brady. And this is what our meetings look like. So we meet a few times a year. Usually it's on Teams, just so we can get as many people to attend as possible. We have the NLCA methodologists, data scientists, statisticians there. We have our project managers, project coordinators. We have the clinical leads, so the experts in respiratory medicine, oncology, surgery. Our PPI chair, so that is a patient with lung cancer who is the chair of the meeting, who runs the meeting and kind of gets everybody involved. And we have the patients, relatives, friends, carers, everybody. And we just talk about, those meetings are really jam-packed. We talk about so many things, but they're actually really enjoyable meetings. We have a lovely atmosphere in the meetings, and I feel like everybody gets their voice heard. Next slide, please, Verity. So how do the PPI contribute to what comes out of the audit? So every year, as you've heard, each audit produces a State of the Nation report, which really gives a snapshot of a whole year of the patterns of care and the outcomes of patients with lung cancer. Next slide, please. And the way that the PPI Forum for Lung Cancer, for the lung cancer audit has contributed to that is because they first asked, how can we help patients to understand these outputs? So now what all the audits do is we produce, at the same time as our State of the Nation report, we produce a patient public version of that report. And this is the one that we produced this year. And it's very much targeted at what patients would want to know. We don't use so much technical language about the statistics. We explain it in a way that's accessible to the public and patient groups. And here you can see that we thank and acknowledge our PPI forum for guidance in putting that report together. Next slide, please. The other way that the PPI forum has really guided that report is they asked, how can we present data in more meaningful ways? How can we make the most amount of people understand what we're trying to say? And one thing that they told me was that not everybody is a percentage person. Some people actually prefer to think about it in ways of so many patients out of so many patients. So that's what we do in our patient public version of the report. We actually present it in a slightly different way to say, for example, here, 7 out of 10 patients with small cell lung cancer received chemotherapy, and we set the target as well. We translate the target into that kind of more proportion style, so that no matter which type of thinker you are, there's a way that that's presented in probably the most meaningful way to you. And if we go to the next slide, please, you'll see that we actually produce a whole infographic page that's specifically for patient and public, and it's in that kind of more accessible format as well. Next slide, please. The next thing is that the PPI forum wanted to know, well, why do some patients receive treatment while others do not? And that's probably one of the big questions that we ask ourselves in the audit all the time. But what the PPI forum asking that question led to was was a publication in a peer-reviewed journal, BMJ Oncology, trying to understand why some patients with more advanced non-small cell lung cancer do and don't receive systemic anti-cancer therapies like chemotherapy. And I've just put this kind of timeline down the side of the screen here. And this shows that the PPI Forum were really involved at every stage of developing this paper. So coming up with the initial research idea and helping us refine it to keep it very patient-centered, the way that we designed the study to try and include as many patients as possible in that, the analysis, but then we came back, we presented the data and made sure that the data was presented in a way that was sensitive and important to patients, and then interpretation of the key findings. And as you can see here, in all of the publications that come out of the audit, we specifically mention our colleagues at NATCAN, who give us a lot of help and support with everything, and our PPI forum that really help to keep patients at the centre of what we're doing. Next slide, please. This was, okay, so the resources that we produce for patients really come directly from the PPI forum. And one of the things that they felt when they had their experience of going through lung cancer diagnosis is that they didn't really know what to ask their healthcare team until they got home later on and then remembered all these questions. So what they wanted us to come up with was just quite a short but quick fire list of possible questions that might be important to them. So we sat with the PPI forum and we went through many iterations to come up with this important list of questions. And we also specifically left some free space on that leaflet for patients to write in any of their own as well. Next slide, please. And perhaps one of the most important resources that we have produced as, alongside the PPI forum is this guide to statistics. So the PPI forum asked, how can we help interested patients understand more about the more technical outputs of the audit? So patients and the public that are really interested in more of the data side of things, how can we help them to understand? So we put together this guide to statistics. And it covers a wide range of statistics that we present as part of the audit. So it goes from things such as, what does a percentage mean? So I'm giving some worked examples to help people understand that a bit more. Next slide, please. And perhaps one of the biggest things that we talk about in the audit is averages and different types of averages. So trying to explain how we come up with different types of averages and when we might be using them. And I think that one of the most important points of the whole resource is 10 key messages to remember. And this came directly from our PPI forum, that you are not a number and your care is personal. Next slide, please. And contributions to PPI. So the PPI forum asked, does every patient have access to a lung cancer nurse specialist? And what we decided to do was make that our theme of our quality improvement initiative. So we want to make sure that every patient that's diagnosed with lung cancer in England is having support from a specialist nurse. So we've worked up with the Association for Lung Cancer Nurses in UK, which is Lung Cancer Nursing UK. We put together a poster to try and help them advocate for patients more and get the right number of lung cancer nurse specialists in each trust. And we've gone through many iterations to make this the most suitable quality improvement intervention. And here's a lovely photo from a QI event with NATCAN. And this really just shows the diversity of our team, because there are clinicians, there are data scientists, methodologists, and patient representatives all in that photo. And if you just press the next button, please. I think one of the most important things that a patient said during our discussions about the QKIT, about the quality improvement intervention, was think beyond the data and think about what the data actually means. And that's something that's really stayed with me when I've been looking at data since then, because it's not just a number on a screen, it's what that actually represents and how we can try and make it better. Next slide, please. Okay, and where are we going next with the audit? So what's lovely about our PPI forum is that they have a lot of ideas, and they really keep asking those important questions, which helps us guide the audit to better patient care. So one of the things that's really important in lung cancer at the moment is thinking about the genetic mutations that may have caused that lung cancer, and that comes out in the biomarker data. So we're really trying to get that, and that's something our PPI forum are helping us to push for. And you may have seen on the news that lung cancer screening is really taking off now in England. And we as an audit would like to be able to start reporting on the outcomes of the patients who had screen detected lung cancer. So that's where we're starting to head next. And next slide, please. And I'll just leave you with a quote from our PPI chair. So I mentioned earlier in the meeting that the meetings are chaired by a patient representative, and that's Duncan here. And he says that the patient voice needs to be front and centre in the cancer treatment conversation. And I am convinced that the PPI teams in NATCAN ensure that this continues to be the case. Thank you.
Laura, many thanks for that. It's a really good run through of first audit. We're going to move straight in because of time into the next audit, but Frank's going to introduce the National Non-Hodgkin Lymphoma audit. Frank, over to you.
Thanks, Chris, and good morning, everyone. For those who don't know me, my name is Frank Burrows. I've been with, I'm the chair of the PPI forum for the National NHL audit, and I've been on this programme now since, I think, 2003. And it's great to see the way in which it's developing and finding new conclusions and so on for patients. A bit about my background. I started off in the consumer industry, and I'm an economist by background with a real interest in statistics. And I spent a good decade working out why some supermarkets in the chain I worked for, took more money from in terms of sales every week than other ones. And when I think about it, I mean, that project, I mean, it was massive, and we had huge amounts of data, coming in from checkouts every day on sales. But it's actually very similar to the sorts of things we're doing on the NATCAN project. How do we really understand performance differences, and what can we do? What are the quality improvement initiatives we can make to make performance better? In later years, I was a consultant, and I've worked in healthcare, I've worked in the life sciences industry, and many others, but mostly on big projects involving data to drive improvement. So that's really my passion, is using data to reach new insights and new conclusions to drive improvement. But I must say that this project, it's a pleasure to be involved with it, and it's great to see how it's developing, but it's also a big one. I mean, it's a huge undertaking, and I think it's fantastic the way it's going. So next slide, please. So I retired. I was diagnosed in 2018, and so I retired immediately, and I've been well ever since I was treated. But I think a lot of us, when we get into retirement, we want something useful and meaningful to volunteer for. And so I thought, with my background in data and statistics and so on, that this would be, I jumped at the chance when this audit came along, particularly as I think the way this is going, it's going to have a lasting impact on the lives of so many people, NHL patients across England and Wales. Now, the kinds of activities that I've had the pleasure to be involved with, first of all, attending the quality improvement meetings that Julie talked about. I think what I really like about that opportunity is it brings the 10 audits together so that we can learn from each other and meet other members of PPI Forum and learn from other audits and see the kind of issues and so on that they're dealing with. And I think that's a great opportunity. The second thing, which takes a lot of the time during the year, it's a big priority for us, is the managing the feedback through the patient forum for the annual report, the State of the Nation report. And in previous years, I think a main part of our focus has been plugging the gaps in our data. And that's been a big piece of work, but now we're coming to the end of that. And this year, I think for the first time, the big issues are really starting to emerge for non-Hodgkin's lymphoma. And Christine and Lauren, I think, talked about similar things in their area. What we're finding is that a large proportion of patients present at A&E. So it seems to be a very consistent figure. And we think this goes back maybe for decades, that there's about 30% of patients turn up quite sick at A&E. And what's marvellous about having all the data in such fine detail that we do, the brilliant team of statisticians that we have working on the project are able to show exactly the groupings of patients that comes from. And as you can imagine, it's quite often more elderly patients from poorer groups and also from the minority communities. And I think if we can really get into that and understand why so many patients, and they tend to be sicker at that point, if we can do something about that, then I think we will have the opportunity to make a big improvement to the way in which non-Hodgkin's lymphoma is treated in England and Wales, and will drive the success rates and the levels of the figures for survival up. But the patient version of the report, the PPI version of the report, I think is a wonderful thing, and I think ours is developing tremendously, and I think it'll make a big impact. The other thing I did earlier on, I think Julie referred to this, I had the opportunity to write a blog on explaining my perspective on data-driven quality improvement for patients. And I'm a big believer in that. I'm a big believer in giving patients the information, the data, the information about how the system for healthcare in the UK is performing. And three reasons really. One is potentially about patient choice, although I wouldn't overplay that. But I think it is an important thing. The second one is providing information for patients, so that when they're talking to their cancer nurse specialist or their consultant, if there are issues that they see in the performance of their hospital at the part of the pathway that they've reached, they can raise those concerns and discuss those in some detail. But I think the big issue, the third opportunity for me, is I'm a big believer in transparency. I think giving patients information about how the health system is performing is just a very, very positive thing. I think it's good for the public, and I think it will really help our politics around healthcare in the UK. So it's transparency for me, I think is a really wonderful thing. So that's the sort of thing I wrote about in the blog. The fourth point that we've done a lot of work on in the last year is feeding back for the dashboard. And as others have said, I think the dashboard now is looking very, very good indeed. Clearly, it's got two main groups to provide information for. One of the clinical teams, and the other one is the patients and the public. And maybe our needs are a little bit different. The clinical teams can probably use the statistics side of it in better shape. But I think it's perfectly understandable for the public. For many people in the public domain will get a lot of value, I'm sure, from the dashboard. I think it looks brilliant. And the other thing I've been delighted to do these last 3 years or so is to chair our PPI forum for the audit. And it's just wonderful to make sure that we're getting the patient voice involved. And as others have said, what we do as well is use our links into the charities that operate in this sector, particularly Lymphoma Action and Blood Cancer UK. They have large groups of volunteers that they work with that we can tap into. So, for example, now we're coming up to that time of the year that we're going to do our next State of the Nation report. We can make sure we get many people from those charities contributing to our patient forum as well. So it's been a wonderful opportunity this last 3 or so years to be involved in the audit. I'm sure it's going to have a big impact on people's lives, deliver a lot of benefit for many people, which is a wonderful thing. Personally, I found it great fun, but at times it's also challenging keeping up with the speed and the ideas and the analysis that the brilliant team that we're working with at NATCAN. Clearly, I've got to keep thinking about it. But it is great fun. But of course, none of the work that NATCAN and the audits are doing would be possible without the data. We're taking this vast amount of data that we've got and turning it into information, and also some very powerful insights, I think, about the way in which cancer care is provided in England and Wales. And I think it's a wonderful thing. Well, thanks for listening, and back to you, Chris.
Right, thank you for that. I think you described that really well. None of it would be possible without the data, and that's why it's so important that we get patients involved in how the data gets used. Really important. So we've been through 3 different types of audits. We've done pancreatic, lung, and NHL. I'm just going to widen it slightly out now to just talk about the patient involvement network work that's going on. And Vicky, let's hand over to you.
Thanks very much, Chris. My name is Vicky. I'm the Senior Project Manager for the National Pancreatic Cancer Audit and for the National Non-Hodgkin Lymphoma Audit at NATCAN. And I'm also involved in our PPI work more broadly across NATCAN, and delighted to be here this morning with my colleagues to share updates and news on all the work that we're doing within NATCAN. So, People Involvement Network, PIN, what is it? It's a new, exciting, highly collaborative and supportive space where we have a community of like-minded individuals who offer extensive and varied professional and personal lived experience of the impact of a cancer diagnosis. And our plans for this network when we established this was to expand on the excellent work that's already being undertaken by the individual audit PPI forums within NATCAN. Next slide, please. So why initiate a new network? This is Leslie pictured here. She's the chair of our National Pancreatic Cancer Audit PPI Forum. I think Leslie describes it far better than I can. The network will be invaluable in helping to facilitate collaborative working and the sharing of good practice between audits and in supporting new work on the horizon for NATCAN. I look forward to seeing what possibilities arise because of this important new initiative. So great, we had Leslie's vote to move things forward in our plans for the new network. Membership of PIN. So at the moment we have a core members group which consists of the chairs of all of the current 10 national cancer audits sitting within NATCAN, and we have a small number of NATCAN representatives also part of that group. Myself and the colleagues you see here today are part of that. We do have future expansion plans, I'm excited to say. So our plans are to in time expand to include representation from some of our charity partners, from national patient-focused organisations, to expand to include funder representation and potentially other members of the public. But we're going to take our time doing that. We don't want to run before we can walk, but this is definitely on the horizon for the network. So some of our activities to date, we've discussed and agreed on a name and identity for the network, including the look of the logo that you can see at the top of the screen here. Members of PIN have been involved in supporting wider activities, most recently providing feedback to HQIP, our funders. Members have represented NATCAN at conferences and events such as Frank's Supports Today, and recently provided feedback on the design of some new NATCAN PPI focused web pages. With regard to next steps and activities for the network, we have a second meeting planned in August. We will be developing a short newsletter, thinking about our social media presence, supporting wider activities, future opportunities as they arise, and in the next few months thinking about our new combined data dashboards which are planned for the autumn, and exploring opportunities for influencing policy and giving the consideration, as I just said, to expanding the membership of the network. And I wanted to just mention we will be implementing a speaker program, and my next slide just illustrates some of the topics that we're thinking about for that. So, for example, asking a representative from NHS England to speak about their cancer treatment variation group. I'm just going to pick some of these out. Use My Data. We would love for some of our colleagues that use My Data to come and talk to an audience about why correctly acknowledging patient data matters so much. We thought we could ask our PPI chairs to share their experiences of engaging communities and raising awareness. And we'd also invite data scientists across NATCAN to share more detail about what it is they do day to day in interpreting data and presenting the results. I've got the last slide here, which is to thank everybody for contributing to the presentation this morning, and for being here and finding out more about NATCAN and the work that we do. I'd also like to encourage members of our audience to find out more about NATCAN and the individual audits, and do connect with us. I can see the Q&A has been incredibly quiet. I'm hoping it's Monday morning and maybe we haven't drunk enough coffee yet, but there is other ways to stay in touch. We have a NATCAN email address, we have our social media channels, and of course our web pages, so please do interact with us. Thank you very much, Chris.
Vicky, thank you ever so much. It's a good way to finish that off. If anybody does have any questions, please just don't be shy. Stick them in the Q&A now. We've probably got time for one or two. Just while people think, I suppose one thing that struck me was, I think it's really good that you've got the connections going across the different audits. For the data dashboards, are they targeted at clinical teams, or would they be made public as well? Have your PPI groups talked about that as a concept?
Yeah, I can jump in on that, Chris. Yeah, so they are publicly available, the dashboards. They're developed very much for the sort of the clinical community in mind. But when we've developed the dashboards, we've consulted with members of our PPI reps. So, for example, Frank, you were involved in that consultation last year. So maybe you want to share your experience of that, Frank.
Yeah, thanks, Julie. Yeah, the discussion we had at the time was that there are certain things that clinicians will be very comfortable understanding, such as variation. But those might be more complicated for patients. So the thing was, how do we make sure we don't dumb the data down, we don't dumb the analysis down, but we actually make sure the presentation is as simple and as smooth as possible, that non-specialists can understand it. And I think that's really where we're getting to. So there's one chart which you can look at for any KPI for any hospital. You can see the trend, and that's very straightforward, but it's actually really powerful because it shows what your trend is. Are you going up? Are you going down? Are you operating within the standards that we'd expect, and how do you compare to the national average? So that's a sort of very powerful slide, I think. And particularly as we get more and more data, we can see that over many, many years. The one we really grappled with is about how do we explain variation? How do we show variation? And that's really important because it might be that on average, the trust that the hospital I'm going to is fine, but that average mask is a big spread. So the way in which we're showing variation on the dashboard is, I think it's called a box chart, and I think that's just so powerful. For clinicians, we can show variation in other ways with standard deviations, 3 lots of standard deviations and all that sort of thing, but we don't need to know that as patients and members of the public. But the box chart shows that, I think, very powerfully. And a narrow box means there's actually not much variation, which is good news. A huge box means there's a lot of variation. So that's putting over, I think, quite a complex statistical concept in a very, very simple way. So the thing for the dashboard was, is it visibly intuitive? Is it simple? Will members of the public understand it? And I think we're getting there. I really think we're getting there without losing stuff that consultants and their teams would want to be able to see as well.
That's really helpful, Frank. And in fact, if people haven't looked at the dashboard, they haven't looked at the NATCAN website, I really would encourage you to have a look. There's a huge amount done on there. And the team, I know, genuinely want feedback about where they could be better, where the audits can be better. It's been a very open process. The link to the website is on there. Lauren's put that on kindly. I think, sadly, we have run out of time. Of the one person saying, will the slides be available for us to share with our patient cohort? So I'll pass to Julie in a second, but just to say thank you for the team for putting this together. Thank you, everybody, for attending, and I'll pass to Julie for the final few words. Julie.
Okay, yeah, thank you, Chris and the team at Use My Data for this opportunity. And thank you for everybody who's joined us and has listened to our work in NATCAN. Yes, the slides and the recording of the session today will be available on our website.
Thank you, Julie. In which case, I think we need to draw this morning to a close. Thank you again, everybody, for your kind attention. You know where people are, you know where the website is. Please stay in touch and remain involved, and enjoy the rest of National Patient Data Week. Thank you, everybody.
Thank you.
Thanks, Chris.
Thank you.